Hello. First, in my class series in OPGYN, the topic which I am going to present is uterine inversion. Now, if you are given this picture as a spot diagnosis, what would you think of? The first thing which comes to our mind is prolapse. But then again, if you're told that this woman has just recently delivered, then again, you could think of prolapse, you could think of fibroid, but the most important thing which you must think of is uterine inversion. Why? Because it is a life threatening situation, and if managed then and there in the proper way, it could prove life saving. Now, this is how it looks like. The fundus is turned inside out into the uterine cavity. So the turning inside out of the fundus into the uterine cavity is defined as uterine inversion. It could be acute, means which has occurred immediately, or even could be chronic. Acute inversion is a rare and serious obstetric emergency. Women can sink into profound shock and they can die. Therefore, immediate management of shock and immediate reposition of the uterus can reduce both morbidity and mortality. If we look at the incidence, it's varied 1 in 3,500 to 1 in 20,000 deliveries. This wide range may be related to differences in the definition, the postpartum assessment, and even in the patient population. But in our country, the incidence approximately is 1 in 8,500. Looking at the historical review, Hippocrates in 460 BC mentioned uterine inversion as a postpartum complication. Soranus of Ephesus in 110 AD also identified this condition as some postpartum complication. But it was not until the 16th century, during the time of Ambroise Père, that it was completely understood as this turning inside out of the uterine cavity. And now, thanks to the trained birth attendants and to ultrasound, we can identify it as one of the most dreaded complications of the third stage. And because it can be identified, it is almost a forgotten entity. Coming to the etiology, the two reasons or causes for this occurring are mismanagement of third stage of labor, mainly because of premature traction on the cord and fundal pressure before the placenta separates. And this is because of delivery which is conducted by an untrained accoucher. So if the placenta has not separated, the uterus is still thin and flabby, and you try to pull the cord, then this may result in inversion. There are certain other risk factors like uterine atomy, fundal implantation of a morbidly adherent placenta, manual removal of placenta, precipitate labor. Everything is occurring so suddenly that the whole uterus is pulled along with the placenta outside, short umbilical cord, placenta previa. Even connective tissue disorders like Marfan syndrome and Ehlers-Danlos syndrome, it is more common. But it has been seen that 50% of the cases, there are no risk factors identified and there is no mismanagement of third stage. So what I mean to say here is this condition is unpredictable. Because it is unpredictable, it can occur after any delivery. All healthcare workers must be aware of its diagnosis and its immediate management. Etiology further can be divided into two conditions, spontaneous or induced. Less than 50% are spontaneous, precipitate labor, traction on the cord, or increase intra-abdominal pressure. But more than 50% are due to mismanaged third stage of labor. There are certain contributory and associated factors for which we need to be aware of, like short cord, tough cord, even the Credes maneuver, which was being previously used to deliver the placenta, in which we apply sudden pressure on the fundus, now which has been abandoned, atonic uterus multiparity, even a fibroid polyp can predispose to inversion. Certain associated factors like macrosomia, deliveries conducted by junior staff who are unaware of the condition, IV Pitocin drip, unicornate, and arcuate uterus. These are the various risk factors. Now coming to the pathophysiology. A portion of the uterine wall prolapses through the dilated cervix or indents forward. Relaxation of a part of the uterine wall. Now, because this part of the uterine wall is comparatively lax or relaxed, it comes down through the cervix. Then, if there is simultaneous downward traction on the fundus, then inversion is likely to occur. Let us look at the patient presentation, how a patient comes to us. Puerperal uterine inversion can occur after a vaginal delivery, even after cesarean delivery, and it has been seen occurring through a hysterectomy incision also. Now, the presentation depends on the extent and time of occurrence. So it could be incomplete inversion or complete inversion. You may have identified it earlier, immediately, or after 24 hours or after a month. So depending on that, the patient presents. The main signs and symptoms include mild to severe vaginal bleeding, mild to severe lower abdominal pain. If it is complete, there would be a smooth round mass protruding through the cervix or vagina, and it may cause urinary retention. The most common presentation is of complete uterine inversion, in which the patient presents with severe bleeding, that is PPH, which is often leading to hypovolemic shock. But I would like to mention here that this shock is out of proportion to blood loss. She might have bled excessively, but again, she is in shock because it is a neurogenic shock as well, because of increased vagal tone from stretching of pelvic parasympathetic nerves. When you examine this patient vaginally, you can feel an inverted fundus filling the vagina, truly, which can be identified as a protruding fibroid sometimes. On transabdominal palpation, the uterine fundus is typically absent at its position. In cases of severe prolapse, the inverted uterus may be seen. Whole of the uterus may be lying out of the perineum. Now, for an incomplete uterine inversion, there are more subtle findings. There is minimal blood loss, and it occurs only 10% cases. When we examine through the dilated cervix, we can see the fundus in the uterine cavity. On abdominal examination, there would be a fundal notch, that is, there would be cupping of the fundus. In absence of heavy bleeding or careful examination of fundus, sometimes these patients may be unidentified for days or weeks. Now, because this constriction ring, which is formed by the cervix, cervical constriction ring, over time increases, again, we are unable to identify or recognize inversion. Then if it is delayed, like if it is incomplete and it is not identified, the patient in shock is revived, blood loss is corrected, then in those cases, the patient may go into subacute and chronic stage. In subacute stage, surgical intervention is essential to reposit it, and sometimes it may even become edematous and infected, like in the chronic type, then they may require a hysterectomy. So again, to revise the various signs: lump in the vagina, abdominal tenderness, absence of uterine fundus on abdominal palpation, a polypoidal red mass, which may be seen in the vagina, and at times placenta may be attached to it. Symptoms include severe abdominal pain, sudden cardiovascular collapse, and postpartum hemorrhage. In such cases, when in doubt, you should go for an ultrasound examination. A transabdominal ultrasound in the transverse section shows this typical target sign with a hypoechoic inverted fundus surrounded by a hypoechoic fluid between the fundus and vaginal wall. This is known as the target sign and is typical of inversion. Again, in the sagittal section, you can see a mirror image of the uterus within the endometrial and with the endometrial pseudostripe being seen by the opposing two serosal surfaces. So this is the pseudostripe and this is the mirror inverted position of the uterus, which can be seen. The clinical course, as I had told you earlier also, first is acute, which could be life-threatening. Placenta may or may not be separated. Patient may be in shock, which would be hemorrhagic and neurogenic both. If it is incomplete and patient is revived of the shock, it may be undiagnosed and may go into the subacute stage. So in the subacute stage, patient has lower abdominal pain, persistent bleeding in puparium, heaviness, and discomfort in vagina. If that again is not identified, she may go into the chronic stage with dysuria and sepsis. The differential diagnosis is very important. Should be ruled out from a uterovaginal prolapse, fibroid polyp, postpartum collapse due to any other reason like atony uterus or traumatic uterus. Severe uterine atony may also give similar findings, neurogenic collapse due to other reasons, coagulopathy in which a patient bleeds profusely, and retained placenta without inversion. Classification, depending on the extent of inversion and time of occurrence: first degree, incomplete, in which the fundus is in the endometrial cavity. Second degree is known as complete, in which the fundus protrudes out through the cervix. Third degree is known as prolapsed, in which the fundus protrudes to or beyond the introitus. So something is seen coming out of the introitus. But in fourth degree, which is total, both the uterus and vagina are lying out of the introitus. Depending on the time of occurrence, if it is within 24 hours, it is known as acute. If it is within more than 24 hours but less than 4 weeks postpartum, it is subacute. And if it's there for more than 1 month, it is chronic. You can easily identify the various stages in this picture. First degree, into the endometrial cavity. Second degree, out of the cervix. Third degree, out of the introitus. And fourth degree, uterus and vagina, both out of the introitus. Now, further, the nature of constriction ring. In acute cases, the constriction ring is dilatable and stretchable. And this is the reason why immediate manual reposition helps in correction of the inversion. But in subacute cases, this ring may be stretchable or may be very tight. And so reposition can be done under anesthesia or usually requires a laparotomy and a surgical approach. In chronic cases, this constriction ring is very tight. Even cutting the ring or in various operative procedures, they may damage the uterus, and at times we may need to resort to hysterectomy if the family is complete. A few statistics: in a review into 29 cases of puerperal uterine inversion, 83.4% were acute, 13.9% were chronic, and 2.6% were subacute. So majority of the cases were identified as acute. In another review, it was seen that 90% were complete or prolapsed, and this is how they were identified. Now coming to the management. The goal for management is to replace the uterine fundus to its correct position. The second goal is to manage postpartum hemorrhage and shock. And third, to prevent reinversion. So once you have reposited the fundus of the uterus to its correct position, it is again likely to come out. And various measures need to be taken to prevent this reinversion. The basics for successful management are initially teamwork. You need a whole team, not only obstetric specialists, but also anesthetists and other supporting staff. Resuscitation and repositioning of the uterus have to be undertaken simultaneously. We need to treat shock, and if she's bled a lot, like there's postpartum hemorrhage, basic principles of resuscitation, those of a postpartum hemorrhage drill, need to be followed. The quickest way to treat neurogenic shock, however, is to replace the uterus to its normal position. The initial interventions. First, discontinue uterotonic drugs. Immediately after delivery, for the separation of placenta, we do give uterotonics like oxytocin, methylaldometrin, or even prostaglandins. They help in contraction of the uterus. But once the uterus has come out, they would not help in contraction and would further constrict the constriction ring, like they would make it tight. So they have to be immediately discontinued. Call for immediate assistance, anesthesiology staff, additional obstetric staff, especially more experienced staff, and operating room personnel. We need to alert them because if we are unable to reposit them, she has to be shifted to the operation theater and surgical procedures have to be done. Establish adequate intravenous access and aggressive fluid and blood product resuscitation. And initially, 2 large bore IV lines, 16 gauge in size, have to be placed. If blood is not available, crystalloid solutions up to more than 1 liter have to be given to support blood pressure. At the same time, draw blood for baseline lab tests like CBC coagulation studies, in particularly fibrinogen concentration, prothrombin time, and activated partial thromboplastin time. If she's bled a lot, activate your institutional massive transfusion protocol and give blood. One important thing is that do not remove the placenta. If the placenta is seen attached to the inverted fundus, on removing the placenta, it would bleed profusely, it would remain flabby, and there would be difficulty in reposition. Therefore, with the placenta in situ, it should be reposited. So, as I was telling you, the first treatment is manual reposition, and this is known as the Johnson's maneuver. The basic principle is the uterus has to be lifted into the abdominal cavity above to the level of umbilicus before repositioning can occur. So the uterus has to be lifted, and because of that, there is passive action of uterine ligaments which would help in correcting this inversion. The chances by this method of immediate reduction are 43 to 88%. The whole hand plus 2/3 of forearm is placed in the vagina. With our hand, we need to hold the fundus in the palm and keep the tips of finger at the uterocervical junction. After holding the uterus, the fundus is to be raised to a level higher above so that you can easily gradually lift it to a level of umbilicus. It may be necessary to apply digital pressure constantly for several minutes. By doing this, we place the uterine ligaments under tension, and this tension generated relaxes and widens the cervical ring and facilitates the passage of fundus through the cervical. So this is the first maneuver. And see, this is how it is done. Try to hold the fundus in your palm and lift it above. And once it has reposited, put your fist inside, maintain it in that position till uterotonics are given and the uterus contracts. Timing is very crucial in management. If repositioning takes place before there is edema and before a strong contraction ring develops, the procedure is easily performed. But if manual replacement fails, we can go for the second method, which is the hydrostatic method. And this method should always be considered an operating theater. Once uterine replacement is successful, the uterus should be held in place for a few minutes and uterotonics given to promote contraction and prevent reinversion. But a word of caution here is that if the patient remains unstable hemodynamically after your first attempt at reposition, immediately shift her to the operation theater and consider laparotomy and surgical repair as the options. Now, once you have tried reposition and you're not successful, the second thing which you can do is use of uterine relaxants. Only in those women who are hemodynamically stable. After the use of these relaxants like nitroglycerin, terbutaline, and magnesium sulfate, you can reattempt manual replacement. In addition to uterine relaxants, sometimes inhalational anesthetic agents have been used. Sevoflurane, desflurane, isoflurane. These are comparatively newer agents, but the older ones, halothane and enflurane, are also effective, and they are of low cost, so can be easily used in low resource situations. But there are many concerns regarding their side effects, mainly hepatotoxicity. So the use of these drugs requires controlling maternal airway. So even if they have to be used, this patient has to be intubated. And this is best administered in operation theater. And this is the initial step. So once you've decided to do a laparotomy, Before proceeding, you can give these anesthetic agents and again reattempt manual reposition. The other method is hydrostatic reduction. It is an option if all other interventions have failed and immediately surgical intervention is not possible. The patient is placed in a down position, the reverse Trendelenburg lithotomy position. A bag of warm fluid is hung at least 1 meter above the patient and allowed to flow by gravity or with light pressure through the tubing connected to a celastic ventouse cup. So this ventouse cup is placed in the vagina, and to it a tubing is connected, which is then connected to fluid, which could be ringer lactate. This fluid is held 1 meter above the patient. So this is how, by pressure of gravity, this fluid goes inside. The seal between the perimeter of the cup and vagina prevents leakage of the fluid, and this results in intravaginal hydrostatic pressure, which forces the inverted fundus back to its normal position. But a word of caution here is that you need to rule out a rupture uterus before starting this maneuver. So this is how it is done. Now, if all these two methods have failed, or if you feel the patient is hemodynamically unstable, the patient is shifted promptly to the operating theater, and at laparotomy, after we open the abdomen, we see something like this. In place of the uterus, a constriction ring containing a dimple or a cup or a slit is often seen with the adnexa, fallopian tube, round ligaments, and both ovaries, which are typically pulled into this hole. So this cup-like depression is seen with this constriction. The procedure which is commonly done and which is preferred to start with is the Huntington's procedure. This cup formed by inversion is located, then a clamp, a traumatic clamp, an Alice or Babcock is placed on each round ligament entering the cup, approximately 2 centimeters deep into the cup. The myometrium can be clamped if round ligament cannot be identified. Gently pulling on the clamps exerts upward traction on the inverted fundus. So we apply the clamp and try to pull it up. Then a portion comes out and clamping at 2 centimeter increments further down and then applying traction. All this is repeated till the inversion is corrected. Now, if available, a second operator can place a hand in the vagina and apply upward pressure on the fundus to facilitate this procedure. Or an assistant can pull one of the clamps while the operator pulls the other clamp. So this is how it is less invasive, and this is how the fundus is pulled out from the constriction. Now, this is the second procedure, Holtein's procedure. This was also called as an abdominal hysterotomy by Holtein. Now, in this, an incision approximately 1.5 inches in length is given on the posterior surface of the constriction ring. So we are cutting the constriction ring posteriorly. Surgical release of constriction ring allows manual reduction of the uterine inversion. Manual reduction also can be performed through the vagina or placing a finger abdominally through the myometrial incision to below the fundus. So after giving this nick on the posterior surface of the ring, you can pull out either with the help of your finger or through a finger in the vagina or through clamps, and the fundus is brought to its normal position. Alternatively, the inversion can be corrected using the Huntington's procedure, that is those clamps. After this, after the uterus is put back into its position, the incision which we had given is repaired. Sometimes an anti-incision can also be given if there is some difficulty, but the only disadvantage is a risk of accidental cystostomy, or that means injury to the bladder. So this is how a posterior incision is given, and with the help of clamps or fingers, the fundus is reposited. Now, let us see a few newer surgical procedures. These procedures require further investigation of safety and efficacy, and therefore they cannot be routinely recommended, but they can be performed in cases of need. Just like we've done a laparotomy and repaired it, we can do it through the laparoscopic approach. Laparoscopic assisted reduction of an acute or chronic inversion has been reported. Now, another method is the use of ventouse. The ventouse can be applied onto the fundus or the constriction ring area, and gradually, with the help of suction, the fundus can be brought back into its place. Now, the most important thing is management after correction of the inversion. After the inversion is corrected, the uterus should be held in place and should be monitored till the surgeon is sure that the uterus is firm and its position is stable, because there are high chances that it may reinvert. The fundus can either be held in place with the clinician's hand, a fist in the uterine cavity, or by a hand which is placed externally, or both, one hand inside and one hand outside. Now, after you've reposited, you need to give uterotonic drugs so that reinversion is prevented and hemorrhage is reduced. You can give an oxytocin infusion, 20 to 40 units in 1 liter of crystalloid at a rate of 150 to 200 ml per hour. Other options with or without oxytocin include use of prostaglandins, 5-methyl prostaglandin F2 alpha, 250 micrograms, repeated every 15 to 90 minutes for a maximum of 8 doses. You have to keep on giving these drugs till the uterus contracts. Or misoprostol 800 micrograms intravaginally or rectally, dinoproston 20 milligram rectally has been tried, methyl ergonervin 200 micrograms intramuscularly, provided the patient has no reactive airway disease and has no hypertension, or rather poorly controlled hypertension. Prostaglandins cannot be used in patients who have reactive airway disease. Now, because too much of handling is being done and you're putting your hand inside the uterine cavity, you do need to give antibiotics. Infection, which may be severe, has been described in non-acute uterine inversion, and therefore a single dose of first-generation cephalosporin, cefazolin, is used for endometritis prophylaxis. If the patient has penicillin allergy, we can give a clindamycin or gentamicin so as to cover gram-positive and gram-negative and anaerobic bacteria. So a wide spectrum antibiotic has to be given. Now, what to do if it reinverts? So, management of reinversion. The treatment of reinversion is similar to that of initial inversion. In a single case report, it has been reported the use of abdominal cerclage. That is just like we give a cerclage for recurrent abortions, for cervical incompetence. We can apply an abdominal cerclage here so that the fundus does not come down to the level of cervix. In other case reports, intrauterine balloon or uterine compression sutures have been used. This picture shows the use of a Bakri balloon for prevention of uterine reinversion, which is, I think, the best method. However, the conventional method of uterine packing is also very effective. The only disadvantage being there are high chances of postpartum infection, which can be managed with the use of adequate antibiotic prophylaxis. Mastubara-Yano compression suture has been tried. This consists of 2 longitudinal and 2 transverse sutures. The main aim being to compress the anterior and posterior walls of the uterus together so that the fundus does not come down. Now here, for a subacute uterine inversion, manual reposition would not be successful because the ring is too tight, and here the Halting's procedure can be used. If you have a chronic uterine inversion, even the vaginal approach can be used for repair. Reposition is required if the family is not complete. If you cut the constriction ring anteriorly and then reposit, it is known as Spinelli's approach. If you cut the constriction ring posteriorly, it is the Kussner's approach. Sometimes the woman requires a hysterectomy. Either she has completed her family or there are other indications, then the Chaudhary's technique of vaginal hysterectomy can be applied. Now, what to do after you've corrected the inversion? The most important thing is to debrief the woman about the events surrounding acute uterine inversion. So you have to tell her what happened, why it happened, and how it can be prevented in future. We need to tell her that there are chances of recurrence in future deliveries as well. So she needs a hospital delivery next time with active management of third stage of labor. She should at the same time be reassured that fertility and reproductive outcome are not compromised following surgical correction. So to summarize, we can follow this flow chart. If pubertal uterine inversion has been identified, the woman is in shock, call for assistance, discontinue uterotonic drugs, address airway, breathing and circulation, establish IV access, begin fluid resuscitation, order blood tests, transfuse blood. Then we try to manually replace the fundus of the uterus, which is the Johnson's method. If it is unsuccessful, give uterine relaxants, nitroglycerin, terbutaline, or even inhalational anesthetic agents can be used. If it is still unsuccessful, then do a lactotomy. The Huntington's procedure can be followed. If that is unsuccessful, then you can try bisecting the constriction ring. That is the Holton's procedure. It would eventually be corrected with this, and then after the uterus is put in its normal position, give uterotonic drugs. If the placenta has not separated, await spontaneous separation of the placenta. Placenta would only be, you can only try separation of placenta after the uterus is very well contracted. So puerperal inversion is an incident which cannot always be foreseen, but it is always possible to prevent an incident from happening. If it occurs, replacement takes precedence over resuscitation, but both should ideally take place concurrently. So manage this patient well and save the mother and her right to motherhood. Thank you. If you have any questions, feel free to ask me questions and I would be very happy to answer them. Thank you.